Testing 1 2 1 2 1 2. No, this is my vibe.
That's
This is
right.
my
Smiling.
mac and cheese, but
That's all you can do.
enjoy your food.
I will, thank you.
This is a treat.
It is.
So I
Let me turn this on. Tell me when it's on. Okay. Testing, testing. It's green. Testing. Is it high enough here? Ready?
Yeah, go ahead. I can turn it up in a minute. Start. Sorry.
Go. All right, welcome everyone. Thanks for coming today. My name is Steve Tremaine. I'm a retired hospitalist and chief medical officer from a large system in California that I've been doing quality improvement work now for about a decade or more as a consultant. I've actually been involved in QI my whole career. The last 7 years I've worked with the American Hospital Association's Health Research and Education Trust as they've worked in 34 states and hospitals around the country on a variety of improvement topics. One that I've been involved with for a very long time has been sepsis care, and I've watched the ups and downs of this treacherous journey of what's best for to optimize sepsis care. And so that's why we have the title today of Navigating the Best Practices. So we will go through those and talk about head on about some of the controversial topics that are there today. So thanks for all being here, and welcome to everyone who's out there in the rest of the state of Alabama. I have nothing to disclose that's of any relevance. We do know that it is the #1 cause of inpatient death. Here's some 2014 data, which shows that 11% of patients have sepsis diagnosis at discharge, and almost half of the patients who died had sepsis diagnosis. A key to saving lives with sepsis, and if I forget to say it every time, when I say saving lives, I mean also saving morbidity. The morbidity associated with patients who have survived from sepsis is astounding. So it's not a great, we got them out of the ICU, we got them home, high five all the way around. If we didn't do our very best and do it early, then even though we might have saved their lives, we may not have saved their functional capacity to return anywhere near the life that they had before this. So you need to have a pretty good sepsis sniffer. Unfortunately, we don't have something like that, like TSA has. We should have sepsis sniffer dogs. So the diagnosis is difficult because it's not like an AMI. You know, somebody shows up and they have chest pain, atypical or not, and they have ST elevations, they got a troponin. That's pretty easy, high sensitivity, high specificity of that diagnosis. The same thing for a new onset focal changes in a neuro exam. So it's not like that. We'll talk about trauma. Trauma's pretty easy to detect too. I mean, your eyes tell you the story of trauma. So this is different. The other thing is the patient status changes during the encounter. They can come in looking fairly well and pretty much spiral downhill in a matter of an hour or two. I remember when we were working on sepsis in my ED, I asked the chief of the ED, I said, David, what scares you most about the ED, the patients in the ED? And he said, actually what scares me most are the patients that are in the lobby. They may have been triaged once, but how often do we triage them? How long do they wait? And we started actually re-triaging patients after about every hour, because patients who came in low acuity triage level 3 could be a 2 or a 1 in a matter of an hour or two, particularly if they're there for a febrile disease. The diagnosis is not black and white. The patient may look good and yet crash 2 hours later, and this is particularly true with young, healthy people. I always got nervous. The residents were always comfortable, but I was nervous when the patient came in and that 25-year-old was in sick and had a blood pressure of 160/90, because what that meant to me was they would just squeeze their entire adrenal gland, and every molecule of epi and norepi they could make was out there, and then they went to 80/40 pretty quickly sometimes. So be careful when they look really good and yet they may crash. And we're trained to observe. We're trained typically to be cognitive. We're trained to not shoot before we aim and before we think. Yet sometimes by doing so we lose that critical window of opportunity. And of course, there's all sorts of human factors. There's many things going on either in your office or on the floors or in the ED or wherever, and we can get led down that garden path by that patient looking a little bit more well than they actually are. Now, there's two screening tools that have come into play in the last 20 years. SIRS goes back to about 2000, 2001 with the Rivers article. And these are your systemic inflammatory response syndrome markers, any 2 or more of an elevated or low temp, heart rate above 90, a respiratory rate above 20, or a PaCO2 32. The white counts low or high, or 10% bands, with signs or symptoms of an infection. I remember one of my early battles with sepsis was with an ED doc who was a big runner. And he said, hey, are you telling me that every time that I come in from a run, I meet SIRS criteria? And I said, do you have evidence of an infection when you run? He said, no. And I said, that's good, because otherwise you probably shouldn't be running. It's 2 or more of these criteria with signs and symptoms suspicious for an infection. And then what's recently come out of the literature and the critical care folks is QSOFA, so SOFA Sequential Organ Failure Assessment, and the Q is for the quick SOFA. Excuse me. Decreased blood pressure, systolic less than 110, increased respiratory rate above 22, or a change in the level of consciousness on the Glasgow Coma Scale to less than 15. Now, there's a couple things with the QSOFA that make it good and some make it a little harder. You have to know the pre-morbid Glasgow Coma Scale of the patient, obviously. If they already were at 14, then this isn't going to help you very much. And the other thing you have to do is you have to make sure you have an accurate count of the, well, except for the pain score, of the worst vital sign in medicine, which is respiratory rate. Why is it the worst vital sign? When's the last time somebody stood there for 30 seconds, like everybody in this room was taught to do, and count the respirations and multiply them by 2? So I remember the day when my chief of medicine got all the nurses together and said, how come everybody's breathing fast on our unit, on our floor? And they said, what do you mean? And he pulled out, this is back in the days of paper, and he pulled out all the bedside clipboards, and they were all respiratory rates at 20. Because normal is 14 to 16. So if you don't count it, you don't know. And so we know that with rapid response teams, one of the real hallmarks is a rising respiratory rate up through 26 to 28. But it has to be counted accurately for that to happen, which means somebody has to actually invest 30 seconds of their day in doing it right. So just cautionary statements about respiratory rates. Now, either one of these, two SIRS or 2 QSOFA, the SIRS with suspicion of an infection, increase the probability that the patient has sepsis. They're not perfect. We'll talk about the failings, and we'll talk about some ways of understanding and how we go forward. Positive sepsis screen, just going over this, none of this is new. It's the 3-hour bundle. We measure the lactate. Lactate is very important. Lactate is a good measure for many reasons, some of which we may not understand, but obviously it represents a cellular anaerobic metabolism. Obtain blood cultures prior to administration of antibiotics. We've been in some organizations where that's a problem, and sometimes it's a problem because the docs just want to get the antibiotics in, and sometimes it's a problem because there are delays in getting blood cultures. So wherever you are, as you're listening to this, look at your ability to get blood cultures promptly. It's very, very, very hard. I mean, we're shooting blind down the road. You know, we talk about, one of the arguments which we'll touch on is how does jumping in there and treating sepsis, how is it in line with antibiotic stewardship? And we'll talk about that. But one of the ways it's in line with it is we do need effective blood cultures, and we need those blood cultures at 48 hours. We need to know what we're dealing with, and if we shoot first and ask questions later, we shoot the antibiotics in and we don't get the blood cultures, typically those blood cultures will come up sterile, and we have no information to guide us down the road. So docs, hold your horses for a few minutes. Somebody get those blood cultures. If the lab can't do it, stat, then we need to work with nurse. We need to fix that system, or we need to have the nurses be able to do it, if that's what you're doing. There also are some devices out there which I have no conflict of interest in. I wish I had invented them. There are a couple of companies that are making vacuum draw containers that actually take the first half cc of blood out into a side port and wastes the blood. And so it minimizes skin contaminants by about 95% in those specimens. So there's ways to do this, but it's just not okay to have a pattern of antibiotic use without blood cultures, because where are you now 48 hours from now? Now, the world is changing fairly fast on this. There are organizations like BioFire and others that are able, using polymerase chain reaction, to identify the DNA of bacteria. And of course, encoded in the DNA are also their resistance patterns. So this may change as we go forward in the next 3 to 5 to 7 years. And we may be able to get better. The specificity and sensitivity is still not great. There was an article published in the last 2 weeks about this that showed that as compared to blood cultures as the gold standard, when done properly, these are accurate about a sensitivity and specificity of about 90%. So we're getting there, but I don't know that we're quite ready to jettison the blood cultures yet. So maybe if we give this talk in 5 to 10 years, we won't have to talk a lot about timing of blood cultures. Administering broad-spectrum antibiotics, the earlier the better. We'll talk about that. And the crystalloid, another potentially controversial topic, of 30 milligrams per kilogram of ideal body weight. 30 milligrams per kilogram of ideal body weight for hypotension or lactate greater than or equal to 4. There's your 6-hour bundle. I'm not going to go to this in details, but this is for persistent hypotension or lactate greater than 4. We'll come back to this when we talk a little bit about some of the studies that have seemingly refute the need for early rapid fluids. Applying vasopressors to keep a MAP of 65, reassessing volume status, and remeasure the lactate. A lot of organizations now, if your lactate is 4 or greater, or even 2 or greater, are doing what are called reflex lactates, which means that a couple hours later, lactate is routinely done. EMRs are challenged by this because the patient may not be in the ED in the 3rd or 4th hour, and sometimes those automatic reflex lactates are auto-canceled by the EMR when the patient goes to another site of care and gets it's time for it again. Then people forget about it. Updates. I think this is kind of fun. I went to medical school in the mid-70s. I've kind of practiced through the old ways, the new ways, and here we are going back into the old ways a little bit. So we're no longer requiring CVP or SCVO2s for all patients with lactate greater than 4. It's not supported by the current evidence. Dynamic measures are better than static measures, so these pressure readings are static, and they're now recommended to predict fluid responsiveness where they're available. One set is always available. I'll show you about it. And the next thing, of course, is frequent assessment of the patient's volume status, both so you adequately give people volume and that you don't blindly just keep them running wide open. So here's a return to the past, back to the future. We learned to do this in the 70s, and it is simply looking at what happens when you raise and lower the legs. And here we are again. This is now very approved, in fact, in some studies superior. And according to the Society of Critical Care Medicine, this is probably better than the static measures of. So we're not sticking lines in. We don't have to have the fight about is it IJ, is it subclavian, is it femoral vein, because unless we need that vein for volume resuscitation, we no longer need it for measuring pressures. And then if you have the capacity to do bedside cardiovascular ultrasound of the IVC, that's great. So here are new but old measures. So what are the controversies? Let's go through these 4. SIRS or Q-sulfa or clinical judgment or what? The timing of antibiotics, fluid, when, and how much, and the 1-hour bundle, the on again, off again, on again 1-hour bundle. Diagnosis sepsis. So the first thing I hear from people is, don't sepsis screens cry wolf? Yes, and there often is one. So my daughter has a German Shepherd, and he's about 7, and I don't think his vision was ever very good, but if she's visiting in my house, and the dog has lived there a lot when she was younger, and I walk into the door, the dog will bark and charge at me. And when he gets 10 feet away, I don't even say anything. When he gets 10 feet away, he cowers, he lowers his ears, he turns around as if to say, oh, sorry, it's you again. And I asked my daughter, would you rather have him do that or stay in the kitchen until he really knows whether it's an intruder or not before he barks? What do you think her answer was? What would you rather have with your dog? Wait until the intruder's in the kitchen, or bark at dad, grandpa, when he's coming in the front door? So her answer was clearly the latter. I would rather have more, I don't want to miss it. I don't want this to happen too late. And I think we have to think about this because there is still a tremendous amount of literature that shows that the lack of early response to sepsis not only leads to increased mortality, but increased degrees of morbidity. And we will, if I forget, remind me, we'll talk about morbidity. So here we go. Who really liked their biostatistics class in med school or nursing school or whatever school you went to? Who loved it? Who wanted to take it again? Who had to take it again? Never mind. Don't raise your hand. So what is sensitivity? Sensitivity is the ability of a test to find something that's there. And specificity is the ability of a test to not find something that's not there. Okay? And sensitivity and specificity lead to a predictive value only when you know what the expected prevalence is of whatever you're looking for in the population that you're testing. Okay? So way back in the day when I was a baby doc in California, we did treadmills, ETTs for the local fire department. And I got these 30-year-old hunks of firefighters that are lifting weight every day on the job because they're wearing 100-pound packs. And they're lifting weights for fun when they're not working. And they walk in there and, they may have family history and they may not, but not at 30. And we're doing these tests on them. And best estimate of the sensitivity and specificity of an exercise treadmill back in the day was about 90% sensitivity and 90% specificity. And if the prevalence in the population that we're testing is 1 in 1,000 or whatever, you do the math. I'm not going to do it in front of you, but if you do the math, you'll find out that about 999 out of every 1,000 positive ETTs were in fact false positives. So even though they got these sterling 90% sensitivity and specificities because of the prevalence in the environment. So if you did sensitivity and specificity on the SIRS criteria or QSOFA, you did it on a bunch of people coming in who clearly were not about to die, let's take the clearest ones, then you're gonna overcall it. There's no question. The problem with sepsis is that there's this window. We know the really sick ones when they come in. And we pretty much know who's really well when they come in. It's the people in the middle. And so when you look at a lot of the sensitivity and specificity studies that have been done on SIRS, it's about 60 to 70%, which means that it's about 60 to 70% specificity. So the sensitivity is high because the test is designed not to miss it when it's there. But the specificity is only about 60, 65%, which means roughly a third of the time it's going to call it when it's not there. Now, we have a choice. We have several choices here. We can change the sensitivity and specificity. We worked with a different hospital in Alabama that decided that the criteria weren't good, and so they made up their own, and they changed the heart rate to 110, and they found that their specificity got better. I encourage you not to create new science in your own organization unless you study it. And I asked them how many they were missing then. What happened to their sensitivity? Because whenever you tighten specificity, you will worsen sensitivity. And you can't have both. And so if you tighten specificity, and they went back and then started looking at their data, which they had not done yet. And I said, look at the patients who were diagnosed 6 hours, 12 hours. Look at the patients that were admitted and were diagnosed with sepsis until the first post-admission day. They went back and readopted the SIRS criteria of 90. So you can't just make this stuff up. If you tighten the specificity, you squeeze the sensitivity. So you have to ask yourself, where do you want to err? All right, and there's no perfect test, so it'd be nice if there was. All right, let's timing of antibiotics. Been a big push since the beginning of the Surviving Sepsis campaign, now almost 20 years ago, to push the antibiotics early. And then Michael Klompus, who is the lovely contrarian editor of JAMA, published this just about 9 months ago now. And it's the antibiotic for sepsis. So it's really funny because, and look at this. This is a worthwhile article to look at. A follow-up to that, he presents this case. And And he determines whether he would give the patient antibiotics or not. And he calls on another colleague, a woman who's younger than him, and she takes the whole counter position that she would give the patient antibiotics. So we realize it's not easy, but there is a way to marry stewardship of antibiotics with treatment of sepsis. And the first thing is, you know your antibiogram. You make every effort to identify the source. You understand the patient's allergies and any recent history of exposures to antibiotics. And you pick the antibiotic that makes sense out of that. You don't do antibiotic X because that's what you always do. You do have the capacity to customize some of the care. You don't have to throw the kitchen sink. You don't have to do multiple therapies. At least try to narrow it down to what's the patient's sensitivity based on what's our sensitivity in our community. Know your antibiogram. How many of you know or have ready access in your order sets for antibiotics, your antibiogram? Right in the order set, tells you what to do. So this exists, and it exists in a lot of places. And it exists at East Alabama Medical Center in Auburn, where they've been doing this for a decade. And the physicians are guided. The physician still gets to make the final decision. This is not robotic care. But the physician is guided based on the antibiogram and the suspected source of the infection and the patient's pen allergic or not as to what the best sepsis antibiotic is or combination is. So this is how you marry stewardship. The other way you marry it is you're constantly reassessing the patient, because I told you 1/3 of the time you may be overcalling it, but if you don't overcall it, then you're going to undercall it. And when you undercall it, the delays are clearly linked to increased morbidity and increased mortality. Some studies show by as much as 7% for every hour of the delay of antibiotics. So what you do is you need to continue to reassess that. And it's really okay at 6, 12, 18, 24 hours to say, okay, now it's clear. Now the patient's been under study and we can pull back. Or at 48 hours, we can say, now everything's negative. The cultures were done before the antibiotics were given, and we can say, okay, there's no growth. The patient's done really well. It was something else, okay? Now, the role of procalcitonin in all this is also not as rosy as we would like it to be. So it's a tool, but its own sensitivity and specificity is not so ideal. It would be great if it could tell us right off the bat whether the patient had a bacterial or a viral infection. So I think there is a way to do this and not just be blindly throwing antibiotics at patients. Antibiotic-driven, source if known driven, order sets, de-escalate as promptly as clinically indicated, balance need versus overuse, and remember, an hour delay costs lives. Fluids. Not controversial at all, is it? All right. Well, I'm going to challenge you, because a lot of the studies that come out, the Prospect and all the other ones, Promise, we are busy people. We fall into the trap of reading abstracts and not reading articles and not looking at tables and graphs in articles. And if you've read these studies and you thought that it kind of washed away, pun intended, washed away the need for all these fluids, then go back and read them, because you didn't read them completely and correctly. I challenge you to do that. Because in those studies, they're really comparing aggressive, ongoing fluids. In virtually every one of those studies, every patient, both control arm and not, intervention arm, got 30 mLs per kilo of ideal body weight. So, and why is that? Why do you think that is? What happens? I'm not allowed to wander here. I'd be wandering right now. They got me in this box, which I grew up in a very Italian neighborhood, and making me stand here and not move is just really hard to talk at the same time. So why do you think that is? So let's do some studies in 2015, 2016, and let's tell the doctors in the control arm they can't give fluids. What would happen to your study? What would your IRB do? What would your ethics committee do? The baseline has changed from the 2001 River study until the middle of this decade. And guess what? People are getting their fluids. People are getting their fluids. The whole attention to this over the prior 15 years has caused people to get fluids. And so if you really look at these articles, the early goal-directed therapy, and if you really look at the tables and you look at how much fluids the patients are getting, we're talking about aggressive fluids for the most part beyond the 30 mLs per kilo for the patients that are not responding to pressors, etc. So take a look. If I'm wrong, you can email me and tell me what I missed. But the idea, I think, of these articles is not to just blindly keep giving fluids until you get a pressure that you want. Okay? There does come a day when you have to stop. But they're really not, when you look at the details, to tell you don't give 30 mLs per kilo. And again, ideal body weight, I've had lots of talks with ER docs who said, I can't give this 300-pounder 30 mLs per kilo. They weigh 150 kilos. That's, you want me to run in 4,500 mLs? It's like, no, they're like 5'8". Their ideal body weight is probably 70 kilos. I do want you to run in 2,100 mLs. So that's another thing that people forget. All right. Now the other thing that has come out is, what about this fluids and saving mortality? And that remains in the flux. In fact, since I prepared this talk for you, just in the last month or so, has anybody seen this study of phenotypes of sepsis? So, this is the best part of my job. I get paid to read articles. It's awesome. Only time ever in my life. So there's this new thing where they're looking at phenotypes, because there's been this question, are some patients worsened by excess fluids and others not? And we're very early in this game, but again, they're all based on the PROMISE and other studies, which means they all, for the most part, got their 30 mLs per kilo anyway. We're talking about extra fluids. But people have challenged whether the fluids really make a difference. So I think we can argue that antibiotics clearly make a difference, early antibiotics. Fluids, maybe not so much, except in one group, and I'll come back to that. So this is my issue with the confounders in some of these studies, is that usual care has migrated, and usual care, best usual care, which was the control arm of those studies, got 30 mLs per kilo for the most part. It wasn't designed that way, but for the most part, if you look at all the tables they have there, that's what patients got. All right. Now, what about CHF in chronic renal failure patients? Those are the ones y'all most nervous about? Yeah. So Vincent Liu, who I know, who's an intensivist and a researcher for Kaiser, California, and he's got about 17 hospitals in Northern California with intensive care units to pull data from. He and his colleague did this study. And it's 2015, I think. And this is from his study. Decreased hospital mortality was observed primarily in patients with heart failure and or kidney disease, p less than 0.01, compared with patients without this history, p less than 0.4. So maybe fluids are not that important with everybody, but they're most important in the patients you're afraid of giving them to. And that's the lesson from this and other studies that support this. Does that make sense? Why are they there? Did they show up because they have heart failure today? They show up because they're septic. What happens to your systemic vascular resistance when you're septic? It goes down. What happens to your blood pressure when it goes down? In order to maintain blood pressure, you have to either squeeze those vessels or you got to fill them with fluid. If while you were sleeping last night, I changed all the pipes in your body from 1/2-inch pipe to 1-inch pipe, what would your blood pressure be this morning? It would drop. Okay? That's what sepsis does. It drops SVR. So blood pressure is going to drop. So you need fluids. So if you got somebody with congestive heart failure, what do they need to be on their Starling curve to get optimum cardiac output? At the top, right? They need good filling pressures. Lousy filling pressures, and you got a floppy heart, and it doesn't put out stroke volume. Chronic renal failure patients, what do they need to perfuse the kidneys? A pressure head, right? Pressure goes down, what happens to your kidneys? They stop working. So this shouldn't be, when we think about this, this should not be a surprise. Our fear is based on this history, and our fear is one of the age-old fears of medicine. The act of commission. I did something and the patient got worse. We fear this as human beings, and that's okay, that's a good thing. We are just beginning now to fear I didn't do something I maybe should have, and the patient got worse. For most of my career, the focus was on acts of commission, not acts of omission. And now acts of omission are kind of taking the same seat at the table of acts of commission. Failing to do something that's appropriate is no less of a sin than doing something that wasn't appropriate. So I think we have to ask ourselves, the patient shows up with these conditions, they need fluids. And this is where the evidence is. Now what happens? What happens? On day 3, what happens? With these patients who recover, what happens? They get fluid overloaded, right? All you did was give them those 3 liters on day 1, and now they're fluid overloaded on day 3. See, I shouldn't have done it. No. Do the happy dance. They're alive. And they might be alive because you gave them the fluids. Now, what about the ones that don't make it? What do you say? Do you ever say, if I'd have just given them those 30 mLs per kilo that I was afraid to give them, that they'd be alive today? Or do you say, man, they were sick. It's unfortunate. Most of us say the latter. So as Sean Townsend, who I have the great joy of working with Surviving Sepsis Campaign, says, I can treat volume overload. I know how to do that. I have lots of tools. And if I get the opportunity in a chronic heart failure patient to treat fluid overload on day 3, then that means we have succeeded. And I got many ways I can do that. But if we didn't give it and they die, I have yet to figure out how to treat dead. Yet to figure out how to treat dead. And traditionally, we blame that on the disease, not on our own behavior. All right, delays increase mortality. This is a study from Critical Care Medicine from just last year. Shorter delays improve outcomes. There's no evidence that 3 hours is safe. We have a 3-hour bundle. But if we get everything done and get it started and get it all going at 2:59, do we do that high five happy dance? No, there's no evidence that 3 hours is like the promised land, that we could not have done better if we did it at 2 hours or 1 hour. Now, we're not necessarily saying the patient needs to have all the fluids in 1 hour, but we need to get it started and get it going, and not at 100 mLs an hour. Any delay adversely affected outcomes. So let's talk about the on again, off again, back on again 1 hour bundle. Measure lactate. Remeasure it if it's above 2. Obtain blood cultures before administering antibiotics. I mean, we were all taught this in our training. Make sure it happens. If there's unnecessary delays, give the patient antibiotics, and then tell your organization to fix the system. We should not have to give inferior care because we can't get blood cultures done. Inferior care is blood cultures after antibiotics. For an individual patient, you may have to do that, but then somebody needs to take responsibility to fix the system. Administer broad-spectrum antibiotics, but do it with stewardship principles. Begin rapid administration of 30 mLs per liter. Oh, here's another thing. I hear this all the time. The 3 things. 1, SIRS means a suspicion of infection. Okay. 2, we want to give everybody fluids. These are for people with a lactate of 4. We're not telling you to give 30 mLs per kilo to a patient with a lactate of 2.8. So there's a lot of misinformation out there. I'll go totally off piste. I tell my folks, my friends from the Alabama Hospital Association, I never know what I'm going to say. I also do a lot of talking on opioid treatments and opioid stewardship. And the CDC, as many of you know, in the last year or 2 published these recommendations about how to manage chronic pain and all of that. And then several states took it and ran with it and made them very, very harsh and restrictive and said it's the CDC's fault. We're just following the CDC, to the point where the CDC's had to publish statements saying that's not what we said. So be careful with sepsis. What the urban myths about what you're supposed to treat and what you're not supposed to treat, and these levels about when to give fluids and when not to give fluid, may not in fact reflect the best evidence. So here, the best evidence: the fluids are for patients with a lactate of 4, and then the vasopressors to keep them during or after. I mean, you may need to slap the vasopressors on there while you're giving the fluids. If they come in with a MAP of 55 or 50 and you don't have initial response to the fluids, you're not going to wait until all the fluids are in before you put on some pressors. So that's clinical judgment, and that's why it says during or after fluid resuscitation. All right, and then here we have an argument saying, wait a minute, should we be doing this? Maybe we're going too fast with this 1 hour bundle. And after a big powwow of the nation's leaders on sepsis, it's back. And the Society of Critical Care Medicine and Surviving Sepsis have agreed on the 1 hour bundle. Again, the idea here is this. MI, door to balloon, stroke, door to thrombolytics, right? Trauma, the golden hour, right? Sepsis, which kills as many people as any one of those, and more than most, the 1 hour bundle, the hour one bundle as it's called. So first of all, the idea is this is a medical emergency. It's no different than trauma, AMI, or stroke. So this is not time to pussyfoot. We need to get down and get busy, and this patient needs attention, just as if they were a trauma patient, an MI patient, or a stroke patient. Measure that lactate, get those blood cultures, give the antibiotics, begin the fluid administration if they're hypotensive or their lactate is greater than 4, the same as 4, and apply the pressures if you need to. This is it. This is a trauma room patient. This is serious business. This is no less important than those other 3 diagnoses that we have come to realize are medical emergencies. These cards, they make them. I don't work for them. I don't get any money from them. They make these cards. They're pretty nice to have. So where are we at the end of all of this? What is agreed upon by all? Suspect sepsis. Look for it. You know, I just walked through the Newark, New York airport yesterday, and it's interesting. The dogs were not in the terminal. There were several federal agents with their police dogs, with their sniffing dogs, walking along the cars at the curb. What are they looking for? Bombs. They're looking for bombs in the cars. So they're going down there to do that. They're suspecting sepsis. They're not just assuming. I mean, there's never been a bomb in the Newark airport, right? Isn't that the way we think? That never happened. I mean, I have a fight with my wife all the time. God love her. She's put up with me for 45 years. But like we have a small little dog and we run long road trips. She likes to let the dog sit in the front lap. And I said, do you realize if we get in an accident, the airbag will kill the dog and the dog's head will go up into your head and kill you? Am I wrong? And then she said, we're not going to get in an accident. It's never happened before. And then I just say, then take your seatbelt off then. Oh no, I won't do that. So anyway. She's a smart woman who's no less or more logical than all the rest of us. That's the point here, okay? That's the point. So you got to look for it. Now, and if suspicious, don't delay starting your treatment. You can delay, you can start and pull back. I mean, didn't we just launch an attack on Iran last week and pulled it back halfway there? I mean, my God, if the president can do that, you can do that. Launch an attack on sepsis, they say, oh, wait a minute, it's not sepsis, and stop, okay? I'm just saying. Start target antibiotics promptly. You know, don't be so, and I'm not saying you are, but I've been to some medical centers, particularly big university medical centers, where they just don't want to show their underbelly to me. They just sit in a room, circle the wagon, and start telling me how great they are. And that's not why I show up. I show up to try to help people. Somebody once called my team of about 6 us the hummingbirds. We literally go and steal pollen in one flower and drop it into another one. One of the great things we get to do, not to mention hobnob with some of these famous researchers and get paid to read articles, but we also get to go places and steal best practices and drop them somewhere else, then steal something from that hospital and drop it somewhere else. Because we know what to do, but the how to do it, the how-to of the implementation is usually what stymies people. So don't be too proud to check with with the Aloha people here and work with Daryl Childress at East Alabama Medical Center. Okay, my son-in-law is a war eagle, so I have to give that one out there. Just so you know, I do have some conflict of interest. But no, I've been around this country in 34 states and in probably 300 hospitals in the last 6 or 7 years. I have never seen an antibiotic stewardship any better, and never one as good at directed as sepsis is what they're doing just up the road, just up whatever highway that is. So I don't care if you're bleeding crimson, take it anyway. Might save your life. All right, and then everybody with a lactate of 4 or more gets the fluids. Everybody stop pussyfooting, stop dancing, stop trying to figure out whether you should do it or not. Give it. You can fix it if you give too much. You can't fix it if you don't do it. And you may even think, look, I didn't give those 30 milligrams per kilogram and the patient still lived. Tremaine, what are you talking about? What kind of morbidity do we get from patients who have survived sepsis? I'm not sure I have it in here. We'll come back to that. If not, we'll do it on the fly. And don't be afraid of the chronic renal failure. That's a CFH. Now we have chronic failed heart. I made up a new algorithm. Don't fear those CHF and CRF patients. For logical reasons, for physiologic reasons, and proven by very large data sets, they need it the most. And in fact, if we back them all out, it's possible others don't need it so much. On the other hand, who's walking into your hospitals who are sick? What % of patients hitting your ED who are sick have CHF or CRF or both? Lots, right? So, I mean, the 25-year-old can get septic and die. No question. The 75-year-old could get septic and die. So there are higher risks of patients who already have these comorbidities. Remember, they're not showing up because of CRF or CHF today. They're showing up because they're sick and they may very well be septic. That's why they're coming here. That other is a secondary diagnosis. We don't treat secondary diagnoses primarily, we treat primary diagnoses. Nobody's asking you to be a robot though, okay? No one's asking you to be a robot. No one's asking you to stop thinking. I think the physician's job, though, is dramatically changing as we get into the era, which is basically a computing era, where we can look at a lot of this big data, we can look at clinical trials, we can look at meta-analyses, and help us determine what to do, because n equals 1 doesn't show us, and n equals 10, and n equals 100, and not even n equals 1,000. I mean, I can't tell you the number of drugs that have been pulled off the market in my career by the FDA when they were safe for the first 5,000 patients in the trials, but not so safe for the next 50,000 or 500,000 or 5 million patients. So the bigger the N number, the more that we learn, and we have the computing capability now to crunch these big numbers. Our job is to know when the algorithms don't fit that patient. Community-acquired pneumonia. I welcome the day when our organization put in order sets for uncomplicated community-acquired pneumonia. I don't need to think about that. I don't even need to remember what it is. Because guess what? As a human being, you have bad days. You're not always on your game. You are not the 100% best doctor, nurse, respiratory therapist, pharmacist that you've ever been in your life every moment of every day. You're not. No one's ever had a fight with a teenager on the way to work, or a spouse, or a father who fell and broke his hip the night before. We are not perfect. We are not at our best. These are human factors, and we pretend that we can do it best because we're humans, that we're making the same mistake that we've always made. But this time, we don't have an excuse because we have all these guides to send us in the right direction. On the other hand, I can't write an algorithm for community-acquired pneumonia in the middle of an AMI and a stroke and a diabetic who's septic, okay? Or that community-acquired pneumonia algorithm may not fit that patient. But not because I don't like it and not because I don't believe in algorithms, because it doesn't fit the patient. And then I override that and I treat the patient. It's no different than flying. I fly too much. And there's an old joke amongst those of us who fly a lot. Guy got on an airplane and he looked in the cockpit and he saw a Doberman. And he went back and he sat down on his seat and he just couldn't get this out of his mind. And they closed the airplane door. Finally, he rang I always say rang the call button, but You know, we're a product of who we are. He rang the flight attendant button, and the flight attendant came over, and he said, is there a dog in the cockpit? And she said, yes. And she said, that's our new safety program. We no longer have a co-pilot, we have a dog. Okay? How's that work? Well, when everything's nominal and the computer can control it based on all of its sensors, clearly they were not flying a MAX 8, that they told the pilot everything was fine, and the pilot is supposed to keep his hands off it. But if the computer runs into data input that says, I don't have an algorithm for that, then a light flashes on the cockpit, and then the pilot takes over. It's like, wouldn't it be that nice in medicine if we had a light that flashed when the algorithm wasn't right for that patient? He said, okay, but what's the dog for? And he said, that's easy. If the pilot touches the control when the light's not flashing, the dog bites him. Medicine is becoming more and more and more where best practices built into our order sets with the ability to override them when they don't fit the input that you're getting. But it's not because it's Tuesday morning or because I had a fight with my wife or my husband or because I don't feel like it or because I don't believe in algorithms. It should require you, and I was a CMIO as well, and we built these into our systems, require you to document why you're skiing off-piste. Why are you going out of bounds? Why are you overriding the algorithm? And the reason to do that is so we can create a learning environment. It's not for punishment. Maybe the algorithm's not right. Maybe we didn't input it into the EMR right. Maybe we need to beef it up for this comorbidity. Maybe if we beefed it up for that comorbidity, it'd make it so weighty nobody could get through it. But it's for learning. It's for learning. And some of you might think your sepsis sniffer is better than SIRS. Well, then let's test it. Keep track of it. You keep track of it. Go through the next 10 or 20 or 30 patients, or the ones in the past, and look and see at what hour you finally diagnosed sepsis and whether you were right or wrong. Is your sepsis sniffer better than this? Is the sensitivity 95% and is the specificity 65%? If not, you better rely on SIRS. Frankly, I've thrown that challenge out and no one has ever either done it or had the courage to tell me that they were worse than the SIRS criteria. Segment your morbidity and mortality results, and this is where your organization can help you. So you can look and see, forget about CMS and all that right now. This is talking about taking care of patients so you learn. This isn't a regulatory issue. Look at the patients who got the criteria, got their criteria met for fluids and antibiotics. How'd they do? Versus the patients who were diagnosed with sepsis ultimately and didn't meet the early resuscitation guidelines. How'd they do? Not whether they died or not, that's a pretty blunt instrument, death or not. But what about morbidity? I'm going to see if I have it in here. No, so I want to talk about morbidity here for a second. First of all, some of the broad ICU morbidity, because all these patients end up in the ICU. 40% of ICU patients end up with some form of PTSD. Some form of PTSD, delirium. Functional loss can be huge. We have a patient who's given us some testimonials at times. She was septic. She was about a 38-year-old accountant at the time, and everybody did she came in very sick, and everybody did the high five when she left. And 3 months after that, she still could not add or subtract. She was an accountant. So mobility issues that occur after sepsis. So again, the blunt instruments is did they die or did they live? But then we need to look a little more at the human aspects. Did they go home or did they go to some sort of extended care? Did they go home and did they return to the workforce? Did they return to their normal work? What happened to their everyday functioning? What's their cognitive tests look like? Patients with delirium have been reported to lose as many as 3 IQ points per day of delirium permanently. And we know a lot of sepsis patients have delirium. So don't just look and say, well, it worked and I didn't give the fluids and they lived. It might have done better. And I really want I really implore your organization. As we have made a lot of progress on sepsis mortality in these last several years, the spotlight is now turning towards sepsis morbidity and minimizing the morbidity and then acknowledging the morbidity and making sure that the handoffs after they leave the ICU are appropriate. And the best part about these learning environments is we call them learning loops, is you get to continue to learn and learn as a group, learn together. I love this expression that I heard many years ago in quality. We spent most of my career chasing the bottom tail of the bell-shaped curve of physicians. You know, that 1 in 40, that 2%, you know, if we could just get rid of them, our quality would be better, right? How much time have organizations in this country spent just trying to get rid of the worst 2.5% of doctors, while doing nothing with the other 97.5%? There's a lot of evidence now to show if we float all boats, if we do systems like this, we improve everybody's care, and the net benefit is much greater than just doing the punitive side. If we make everybody a little bit better, using not just knowledge, but systems. You get a Groundhog Day every time we treat a sepsis patient. Raise your hand if you've not seen that movie. Oh, good. Okay. I mean, it's priceless. Because what's he do? He learns one thing every time. So in quality, we talk about iterative cycles of improvement. And it's the perfect movie that shows iterative cycles of improvement. I mean, there's the one scene where she shows up at the bar and he's actually got the beer order that she liked because he remembered it from the loop the day before, right? So that's what your learning should be. It should be iterative and learning. But your patient doesn't get another Groundhog Day. They get one shot at you doing it right and doing it in a timely manner and not being too tied up in sort of some of our old world values of what being a physician is and moving towards a new world values, which it is to be able to interpret what we're seeing in light of what's best practices. And if we're going to, as I said, if we're going to ski out of bounds, that's still our right and that's still our duty when it's appropriate, and we need to be able to document how we do that. And you got to measure all this. You can't improve what you don't measure. That's the famous Deming quote. So with HRET, this is a resource. It's free to all of you, updated by my colleague Marianne Whitney, who is a 25-year ICU nurse manager at Kaiser Permanente and now works with us. Got a lot of things in there. I'm available. Alaha's available. I'd love to answer your questions. We are on the road right now. If there's any burning questions, we can go for it. If not, what we're going to try to do with these sessions, because we got 20 hospitals on the call as well, is have you forward your questions to your leadership here. We're going to put together a sort of an FAQ list that come out of not only this group, but out of the folks on the video, and we'll get that back out to you as soon as feasible. So anything we need to address at the moment? Nobody threw anything at me? Either you're very attentive or you were very bored, but I didn't see any iPhones out, and that's usually my measurement. All right, thanks everyone. Thank you for your time.